Broadcast is now starting. All attendees are in listen-only mode.
Hello, everybody, and welcome. My name is Kay Gooch. I'm AVP of Healthcare Provider Engagement, and I'd like to welcome you to the first of our quarterly MS 101 Learning Series calls for FY19. I think you'll really enjoy today's call on addressing cognition in MS. We have several guest speakers who will be joining us, and we'll introduce them in just a moment. But first, for today's calls, we'll take questions. Just as a reminder, we'll take questions at the end. And please put your questions in the question box, not in the chat box, but in the question box. And we'll get to those at the end. Or you can also raise your hand at the end, and we'll go through, unmute you, and get your question answered. You'll also get a very brief survey at the end, and we'd appreciate if you take a moment to answer just a very few questions, because it does help us plan these calls and make any changes that you suggest. Also, the 3 calls from fiscal year 18 that we did are now located on the Learning and Development System. So if you didn't have a chance to hear some of those calls, please take the opportunity. You can go in and search for them under MS 101 Learning Series, and you'll be able to listen to those calls again. Or if you want to assign them to someone, you can also do that as well. So now I'd like to bring up Julie Fiol, who is our Senior Manager of MS Information and Resources, who will introduce our speakers for today. So Julie, take it away.
Thanks, Kay. I'm really excited to introduce these next 2 speakers. The first is Dr. Megan Beyer. Dr. Beyer is a rehabilitation neuropsychologist and assistant professor of physical medicine and rehabilitation at the Johns Hopkins University School of Medicine. As a rehabilitation neuropsychologist, she specializes in cognitive rehabilitation, neuropsychological assessment, and psychotherapy interventions. Dr. Beyer's research focuses on characterizing the emotional and cognitive symptoms common to people with MS, refining neuropsychological assessment techniques in this population, and developing interventions to ameliorate or slow MS-related cognitive decline. As part of this line of research, she is currently working to validate a new neuropsychological assessment tool that can be delivered online in patients' homes. So I'd like to welcome Dr. Beyer, and also with us today we have Debbie Bright. Miss Bright has been living with MS for 30 years. She was diagnosed in 1988 with relapsing remitting MS and transitioned to secondary progressive MS approximately 10 years ago. Miss Bright spent her career addressing issues of violence against women, retiring in 2017. She now spends her days with her 2 adult daughters and her granddaughter, Sophia. She also enjoys reading and researching. So I'd like to say thank you to both of you for joining us today, and I'm going to turn it over to you, Dr. Beyer, and to you, Debbie. Thank you.
Thank you. Thanks so much, Julie. Really appreciate it. So today we're going to talk a little bit about cognition in multiple sclerosis, and I'm really excited to have Debbie joining this because she's going to give us a firsthand perspective on what it's like to live with these symptoms, while I'll give you a little bit of what the research tells us. So she's going to give you the real life picture, and I think that's one of the most important pieces. So I'm going to start off by asking Debbie, can you tell us a little bit about yourself and your history with multiple sclerosis?
Certainly, I'd be happy to. I was diagnosed 30 years ago in 1988, and my symptoms began one morning. I literally woke up and both of my feet were numb, kind of like when you fall asleep on your arm and you have those pins and needles feelings. And I didn't think much of it. I was just thinking I must have slept wrong or something, and went to work. Long story short, in 3 days, I was pretty much paralyzed from the waist down. It kept that pins and needles kept going up all the way to my waist, and I was hospitalized. I was told initially that I probably had MS and was released, and within the same year I was diagnosed. I've had several major relapses during that course of when I was relapsing remitting. I've been with forearm crutches, a cane, of course, and even in a wheelchair a couple times. So my relapses were pretty significant and life-changing, of course. And then in about 2010 is when I really started noticing that I wasn't bouncing back from those relapses. I was, retaining a lot of the symptoms, and I was just, and it was more of a slower progression. And inevitably, I was, in fact, diagnosed with secondary progressive around 2010 or so. And I continued to work. I loved my job, and they were very accommodating. And I continued to work until 2017, as Julie mentioned, and I reluctantly retired. I'm happy to report I can walk with a cane and the use of some foot and ankle braces right now, and doing pretty well. Thank you for asking.
Great, thanks so much. Next slide, please. So the first is I want to talk about the prevalence of cognitive difficulties. So we know that up to 65% of individuals with MS will experience some form of cognitive change throughout their lifetime. And this number could be even higher if we look into people that have diagnoses such as secondary progressive or primary progressive MS. Next slide. I wanted to highlight that cognitive dysfunction is not just found in people with advanced MS or people who have been living with it for quite a while. Cognitive changes can be found in all types of MS subtypes, even prior to persons being diagnosed with MS. So even in clinically isolated syndrome and radiologically isolated syndrome, so that sort of pre-MS, maybe one attack, or they're just seeing changes on the MRI, up to 20 to 30 people in these categories can have some cognitive changes. Cognitive changes have been found in benign MS or MS where people think that there's not active symptoms. And we know that 33% of people with relapsing remitting MS have cognitive changes even early in their diagnosis. And again, as I said earlier, these percentages go up the longer people live with MS and in the progressive forms. Next slide, please. So Debbie, can you tell us a little bit about yourself? Have you experienced any changes in your cognition or thinking skills? And if you have, how have those symptoms impacted your life?
Oh, yes, Dr. Beyer, absolutely. In fact, I would say the cognitive or thinking skills was probably one of the most significant variables in making the decision to retire from my job. It got to the point with, if I had many priorities, I would just get stuck. I couldn't figure out where to start. And focus was huge. And even, on not work-related, but personally reading a book, for example, I can only focus for a very limited time. And I love reading, and that's been very discouraging to me. But, I'll read a page, and then I'll think, did I retain all that? And I'll go back. And it's been very difficult to live with some of those symptoms. Thank you for asking.
Great. Thanks for that information. So I wanted to highlight a little bit what Debbie just mentioned, but also the areas that are not usually affected by MS. So when we think of cognitive changes in sort of the general population, we might think of things like dementia or age-related cognitive changes. And those are typically not what is seen in MS. So people with MS typically have their intelligence stays the same, their ability to attend to basic information, take in basic information stays the same. They're able to communicate well. They are able to read, although I'll go into what a little bit more about why Debbie said she experiences some difficulties with retaining information. But most of the time people can comprehend what they're reading. They might have difficulty remembering it. Memory for facts things like how to do math or the meanings of words, that type of memory is usually retained. People typically remember information from their distant childhood or even years prior. And they have usually intact ability to recognize things. A person's name might not come to them right away, but they're able to recognize the person's name if it's said to them. And typically people with MS do not have difficulty with knowing who they are, where they are, about what time of year it is, and why they're in the place. So some of those things are impacted by something like Alzheimer's, but not in people with MS. The things that are commonly affected are how fast people process information, so the speed at which they're processing new information, their ability to attend and concentrate for extended periods of time, or to multitask, word finding, so coming up with that word or a tip of the tongue phenomenon is much more common in people with MS, the ability to acquire new information or to learn, and problem solving, so executive functionings like planning and organizing, as well as some visual spatial organization. So I typically think of that as like the IKEA effect. If somebody were to go to IKEA and have to put something together, that requires some visual spatial organization, and that can sometimes be affected in people with MS. Next slide. So speed of information processing on that last slide was bolded, and the reason for that is that many research studies have found that speed of information is the primary cognitive problem in people with MS, and that it impacts all of the other domains that I talked about. So if you think about it like a pyramid, processing speed and this idea of attention and multitasking are at the base of the pyramid. If those skills are impacted, they can impact everything else. So if a person is listening to a lecture like this, or they're listening to an audiobook, or they're reading, they're processing information at a certain speed. If that speed is above what they can handle, then they're only going to take in a limited amount of information. So their memory is going to be impacted because they're not learning information as quickly and as efficiently as they used to. That speed might also impact how fast somebody can find a word that they're trying to say, or a person's name. And since we store information in certain semantic categories, if the word they're looking for is not in the semantic category that they're using at that time, then it can be harder to get that word out. So speed, attention, working memory, all of those things impact those higher level skills. And so speed might be the primary issue, but people experience that in a lot of different parts of their life. Next slide. So understanding, there's a lot of reasons why people might experience cognitive change over and above the MS etiology, or the MS, the actual anatomy that's impacted by MS. So primary symptoms occur as a result of direct MS-related change in the central nervous system. So having that myelin sheath impacted by the immune system, or cell loss because of atrophy, that would be a primary reason that somebody experiences cognitive change. Next slide. And so I kind of mentioned that. So demyelination and atrophy are the primary symptoms, or one primary reason why people might experience cognitive symptoms, but there's other reasons as well. So next slide. Secondary symptoms occur because of physical changes or medical or pharmacologic treatments that indirectly impact cognition. So an example of this is sometimes people with MS take certain types of bladder medication that are anticholinergics, and that bladder medication can have a strong impact on people's cognition. So it's not directly related to the actual MS damage in the person's brain or spinal cord, but they're taking that medication because of their MS, so it's a secondary cause of cognitive change. Next slide. Debbie, have you ever noticed changes in your thinking skills that are related to things like these secondary symptoms that I'm describing. So maybe that those cognitive skills got worse in the face of fatigue, pain, or medication use.
Absolutely. Fatigue, as probably most of us would say, affects a lot of different functions. And my fatigue is, quite frankly, off the charts. And so when I'm really fatigued as the day goes on, my cognition issues are much worse. It's going to be harder for me to find a word. I just want to second the pyramid that Dr. Beyer just showed. That's exactly everything that I experience in a nutshell. But in terms of pain or medication, fortunately, my pain is rather controlled right now with medication. But if I do experience greater pain one particular day, again, it's like, most of us, if we have a toothache, that's all you're going to be able to think about. And so you're going to find my thinking skills off. When I start a new medication, exactly what Dr. Beyer was explaining, it's going to take a couple weeks to generally acclimate to a new medication. And so during that time, I'm scattered. I may be scattered. Thank you for asking.
Thanks so much. Okay, next slide. A final reason why people might experience cognitive change is what's called tertiary symptoms. And those refer to things like psychological, social, or cultural issues that might interfere with cognition. So a primary example of this is something like depression. Next slide, please. So severe depression has been linked to poor working memory, executive difficulties, so those planning and organizational skills, and even slowed processing speed, which we already know is impacted by MS itself, that primary symptom. Depression is also linked to changes in the brain, such as enlarged temporal horns, hippocampal atrophy, which impacts memory, and memory learning and encoding, which is impacted by MS itself. So when somebody with MS has depression, it's very common for them to have even worse cognitive problems than if they did not have that symptom as well. So next slide, please. We also know that people who experience anxiety with MS have exacerbations or worse cognitive dysfunction, specifically in processing speed. And anxiety is particularly present in people with MS. It's 3 times more common than in the general population. Next slide. I also wanted to describe that these 2 things, depression and anxiety and other mood symptoms, can impact somebody's ability to attend to information. So it might not always directly impact the brain anatomy, but it can impact functioning. So working memory is a really good example of this. Working memory is a temporary storage container that we use while the brain decides what to do with that incoming information. Working memory can hold about 4 to 5 pieces of information at any one time, and it requires mental speed to be able to hang on and rehearse that information. If that information is not rehearsed, then that information is lost or kind of let go of within 10 to 15 seconds. Next slide. So let's give an example here. Can you advance to the next little animation piece? Okay, so let's have the example of somebody reading a book. So somebody with MS is reading a book, and that is taking up one piece of that attention information. Next. Now this person is reading a book and they hear the phone ring. So we have 2 pieces of information being taken up in working memory. When the phone rings, can you hit next? The person might have an anxiety-provoked thought of, oh no, the phone is ringing. No one usually calls at this time. What if mom fell again? So now we have 3 pieces of working memory that are taken up. Okay, next. Then the dog starts barking. Now we're at 4. Next. Again, we have this anxiety-provoked thought of, oh no, the dog's barking. The neighbors are already upset with us. What do we do? So now we already have 1, 2, 3, 4, 5 pieces of information. Our working memory is already overloaded, right? Next step. And then the person has another thought. This is the third time I've read through this paragraph. Why can't I remember what I'm reading? There must be something really wrong. So this is kind of a fake example of what I hear a lot in my office, is that people's negative or anxiety-provoked thoughts can take up room in our working memory, and therefore they're not able to concentrate on the things that are most important or the things that they want to, which is things like reading a book or paying attention to conversations, etc. Next slide. So if we have all this stuff happening, our environmental factors plus the anxiety-induced thoughts, then our working memory gets overloaded, and that can have a significant impact on people's functioning in terms of their cognition. Next. It's also really important to notice that our perception of cognition, not just people with MS, just across the board in general, is really terrible. So humans are very bad at judging their own cognitive functioning. Some people are completely unaware that they have any cognitive deficits at all. Some people overestimate the amount of deficits they have, and there's a limited number of people that are that can be accurate. And typically, people who have emotional symptoms tend to overestimate their cognitive deficits because they're using that example that I just talked about, that their working memory getting overloaded, and they think that there's even something stronger or more terrible happening. Next slide. And just not only mood symptoms can impact our perception, fatigue can also impact our perception, and stress, day-to-day stress, can also impact our perception of cognitive difficulties. Next slide. So Debbie, can you tell us if you have ever experienced symptoms of anxiety or depression, and how did those symptoms impact your cognitive skills?
Sadly, yes. I've probably been depressed, at some level of depression, ever since I've had MS, and that's been 30 years, as I said. And, it's that negative thinking that Dr. Beyer was just referring to. If you have depression and you're constantly thinking about all the things you can't do or are messing up or don't even know where to start, it's really a piling on. In terms of anxiety, yes. I mean, both depression and anxiety are going to make the cognitive symptoms worse. In terms of anxiety, if I go to someplace, a great example is if I go to someplace that I haven't been before. I don't know where the bathrooms are, and I'll get very anxious. And if there's a crowd, it's really hard to process when it's an environment that's overstimulated for me. And so I will get very confused. And one thing that you'll probably notice as I present today is I may forget a word or have trouble getting information out. So depression and anxiety both definitely have an impact on the cognition.
Thanks so much. Next slide, please. So I wanted to just briefly talk about how we assess cognition. So as I said, because people in general, not just people with MS, have difficulty perceiving how accurate their cognition is, it's really important to get some sort of objective benchmark so that people can track their cognition over time. Next slide. So there's a few MS-specific assessments that are really helpful for people with MS. There's the brief repeatable battery and the minimal assessment, or the MACFIMS, the minimal assessment of cognitive functioning in MS. These two batteries are several tests that address the different symptoms that are common to MS that were in that slide that we looked at previously: processing speed, attention, working memory, learning and recall of information, as well as executive functioning. And they can take anywhere from 30 minutes to 90 minutes to administer these batteries, and they usually require a neuropsychologist to administer the assessment. If somebody doesn't have access to a neuropsychologist or somebody who specializes in MS, there's a few briefer assessments that are starting to show up in neurology clinics around the country and internationally. The brief International Cognitive Assessment for MS is a 15-minute assessment that gets at processing speed and learning, and it's now validated in multiple different languages around the world. So that's a really good kind of in-between assessment. And then there's the Symbol Digit Modalities Test, which is 90 seconds, so it takes less than 2 minutes, and that gets at processing speed. Just recently, we now have access to something called the CogEval, which is kind of like the SDMT, but it's a processing speed measure that patients can administer to themselves on an iPad, and it is available on iTunes. So that's another way for patients to access getting some sort of objective benchmark of where they are cognitively. Next. I also think it's important for us to talk about what to do about these symptoms and not just, whether they're there or not. Next slide. So before I dive into some of those interventions, I wanted to talk with Debbie again. So how have you learned to cope with your cognitive symptoms?
Well, thank goodness for technology. With short-term memory, I certainly have apps on my phone that are incredibly helpful. Not only, one that we all use, the calendar, but I use it for multiple functions, set alarms for different things that I need to do. Taking medication midday is something I'm going to forget, so I have a 1 o'clock alarm every day. I have lists and lists and lists on my phone of, if I think of something I need from the grocery store, a movie I want to watch, a book I want to read, and then I can just go to that list on my app and when I'm in the library and find that book and not have difficulty remembering it. In terms of someone calling the MS Society, I do have some tips. One is education. I mean, it's very simple, but very necessary. I think we're very good as a community on educating individuals with MS about physical symptoms, but in terms of cognition and thinking skills, it's relatively new to be addressing that as an individual with MS. That's just my opinion. So I think education's one thing. Otherwise, they may think they're going crazy in addition to having MS. What tips would I recommend? I think some of the things that I've, mentioned, the apps, making lists, writing down. I also do, I'm not big on games in terms of technology, but I do certainly do solitaire. And that's an example of almost missing the word there when I was hesitating. Solitaire online. I do audiobooks to counteract that issue with reading, and just try to keep yourself stimulated every day in some aspect.
Great. And one quick question to follow up. If somebody is having some word finding difficulties, would you find it helpful for the person to slow down and wait for you to finish your sentence, or do you have any thoughts in that sense?
I do. Thank you for asking. I think it's best if you just are patient and wait for me to come up with a word, or wait for me to have an alternative word. Oftentimes, if I can't think of a specific term, I might just try to process internally and come up with a like word.
Okay, great. Thanks so much. Slide. So one thing that I wanted to mention is something called cognitive reserve. So cognitive reserve is the idea that there are some people that have very severe damage to their brain, and yet they are functioning cognitively very well. And then there are some examples of people who have only a couple of lesions, and yet their cognition is seems much more progressed performance-wise. And so the idea of cognitive reserve is that there are some things that help people maintain cognitive functioning even in the face of advanced disease. So there's two pieces of cognitive reserve. One is passive reserve, things that are outside of a person's control, like their baseline intelligence, how big their brain is, and how many neurons they had to start off with. Active reserve is a lot of what Debbie was just talking about. They're activities that keep your brain active and fit. Typically, they tend to be leisure activities, but in many studies, they focused on things like how far somebody got with their education. That piece of it may be outside of an adult person's control. But what I think we can get from this is that people tend to have better cognition, or their cognition remains stable for longer, if they're actively going to things like art museums, taking classes, learning an instrument, learning a new language, even playing brain games, if they continue to work. So anything that keeps their brain active and engaged, and is something that they have to sometimes work at, it doesn't come easily, that can be a skill building that keeps up the active reserve and may help preserve cognitive functioning over time. Next slide. Cognitive rehab is also another option for more direct intervention. So I think of cognitive rehab as kind of like physical therapy for your brain. So it's the relearning of cognitive skills that have been lost, or learning skills or compensatory strategy that gets around the losses or the things that we might have difficulty regaining. So there might be education or evaluation of a person's strengths and weaknesses, retraining or practicing skills that are weaker. So a cognitive rehab specialist might have somebody practice multitasking or attention skills over and over and over again until that becomes easier and they can use that skill in other ways. They also might teach somebody how to use compensatory strategies, like Debbie was talking about, using a calendar or apps or things that help get over the memory. They don't necessarily improve the person's memory, but they teach the person to not rely as heavily on that weaker area, but you still maintain functioning day to day. Cognitive rehab can be done with a speech pathologist, occupational therapy, and in some states, depending on the institution or the state, with neuropsychology as well. Next slide. So just as an example of cognitive reserve, I wanted to show this study here. We can see by these lines, the blue lines indicate active and people who are either had high passive reserve or high active reserve. And we can see that those people that had those high active and passive reserves remain stable over the course of 4.5 years. Whereas the green and the red lines here are people who had low, medium, or low passive reserve, or medium or low active reserve. And so those people who really, the main things is the active reserve, because we have control over that. But we see that if people are highly engaged in activities, that their cognition doesn't change a whole lot over the course of 4.5 years, and that's good news for people with MS. Next slide. I also wanted to throw this out there. So exercise is important for all of us. I think we know that exercise can be sort of the magic bullet in many areas, right? But exercise has also been demonstrated to improve or maintain people's cognitive functioning in MS. So in this particular study, it took people who improved their physical fitness over the course of 12 weeks. And we see that there's that people who improved their physical fitness improved their cognition over the course of that 12 weeks as well. So engaging in exercise has a big impact on cognition. Next slide, please. And was a study called the ACTIVE trial that was done in healthy aging adults, and they looked at this game that's now commercially available called Brain HQ. And they found that over the course of 10 years in this randomized control trial that people improved their processing speed, and their processing speed was better over the course of 10 years because of that initial training and some booster sessions along the way. This software has now been studied in MS at Kessler in New Jersey, and they're finding similar results for people with MS, that this Brain HQ and specifically the subtask of double decision can help improve people's processing speed. We don't have 10 years of trial information, but it would be interesting to see how that develops over time. But it's something that I'm starting to think about recommending to people because processing speed is such an important deficit for people. Next slide, please. So if people have cognitive difficulties and they want some sort of intervention, cognitive rehab is a really good first step because it can help assess what the individual difficulties are and then what that person in particular might need. So you can refer to neuropsychology, speech language pathology, or occupational therapy depending on what the person has access to in their community. Next slide. Debbie, can you tell us a little bit about what treatments have been most helpful to you for treating both the mood symptoms and the cognition symptoms? And then I'll ask the next question as sort of a little bit of a wrap up.
Sure. You know, therapy, obviously. I mean, once you've been assessed and you know, I will say that just having a neuropsychological evaluation was helpful for me. I want to know everything that is available to me. And once you see it on paper, it's depressing, but yet it's also validating when you have symptoms and you're thinking, no wonder I have trouble finding the word, or no wonder I'm having difficulty with short-term memory. And then, you know, after that assessment, getting into a great neuropsychology therapy if you're available in the area for the individuals with MS. And, you know, also I've mentioned the numerous ways I've tried to compensate for the deficits.
Okay, awesome. And I know we've asked you a lot of questions, but do you have any final thoughts or tips that you think would be important for the group listening to know about?
Sure. You know, I think I mentioned it before, I think education on this issue. I think an individual with MS might, you know, fear that they have dementia in addition to MS, and just educating ourselves, not only on physical symptoms of MS, but also these cognitive and thinking issues that may accompany that with individuals with MS. And, you know, don't be afraid to talk about it if somebody's bringing it up to you, and make the appropriate referrals, as Dr. Beyer mentioned.
Wonderful, thank you. Next slide. Okay, I think that's the end. So if we have any questions, I think Debbie and I would both be happy to answer those.
Great. Thank you, Dr. Beyer. And I appreciate so much both you and Debbie joining us today. You did a wonderful job, and it was great to hear from a clinical and a personal experience about what that's like. So I'd like to remind everybody, if you can go into the question box and give us your questions. We'd love to answer those right now. If you'd rather raise your hand and ask a question, we can do that as well. So while we're waiting for people to give us some questions, Dr. Beyer, I wondered if you could just speak a little bit about the cognitive paper that was just published, and a little bit of screening, that sort of thing. If you could just give us a little background on that as well, that would be great.
Yeah, absolutely. So the MS Society recognized that cognition, while it's universally sort of starting to be spoken about, that people with MS are not getting screened for cognitive difficulties regularly. They're not having access to neuropsychological assessments regularly, and there is still quite a gap in people actually getting any type of intervention to improve those symptoms. So they brought together a group of both cognitive experts as well as society and different community organizational leaders and people with MS that also are advocating for improvement in our assessment and treatment of cognition. And spoke about this consensus group came to some decisions about what should every person with MS have access to in not an ideal world, at a minimum, what should they have access to? So that paper is a consensus paper about what the group came to conclusions about. And the overall summary is that each person with MS should have access to at least yearly screening. If those screenings, if there's any positive result on the screening, that somebody should have access to the ability to get a more in-depth cognitive assessment. And each person should also have access to some sort of intervention to improve their functioning at work, at home, and at school. And children, if there's any change in functioning at school, even if they're not screening positive on cognitive tests, then they should have access to a full neuropsychological assessment to make sure that they're getting captured and intervened with early on, and so they have the best success over time. So that paper, I think, is a really big and important step forward in assessing a gap in what people have access to, and hopefully that consensus paper will move the medical field, the research field, and social advocacy and patient groups towards getting access to interventions and assessments.
Great, thank you so much. I know we on our healthcare access team right now are figuring out ways we can push this information out, so we were excited to see it. So we do have a couple of questions. Someone was asking if there are any medications that help with cognitive issues.
That's a good question. You know, there's been some research that looks at things like that are medications that impact dementia, but there hasn't been a lot of success with those medications. There's not really one medication that there's a ton of success with. When people, some people will take stimulant or ADHD medications, and that can be helpful to kind of improve fatigue or improve attention skills, and that has been helpful for some people. And some of the disease-modifying medications like Tysabri, there's some evidence that people have more stable cognition while they're on them, or even maybe like boosts or improvements after being on them. But there's not one medication that's really demonstrated a lot of benefit.
Okay, thank you. So Debbie, I have a question for you right now. Someone asked, at what point did you notice your first cognitive symptoms, and what were they?
Great question. I think it was really when I was transitioning to secondary progressive. It was short-term memory initially, and my children, who are two adults, really were the one that pointed out to me. I might be talking to them on the phone, and the next day I'm telling them the same story. And so my youngest, actually, who is now a nurse, is the one who really pointed it out to me. So I think it was the help of those around me, and it was not only enlightening, but it's terrifying. You're wondering what's going on. And then with work just became overwhelming. As Dr. Beyer on that triangle slide before, it really showed, the more work I had, I was really slowing down instead of being able to process everything. And so work really was when I noticed personally those issues. Thanks for asking.
Just piggybacking on what Debbie was saying, a lot of times I hear from people, and Debbie, maybe you can speak to this, that they don't even necessarily notice the cognitive problems, but they notice that they used to work 8 hours a day, and now they're working 9 hours a day, and then it becomes 10 hours a day, and now they're working nights and weekends just to get the same amount of work done. And so, did you?
Yes, absolutely. There was a major project at work, and I really was trying to push 50 hours plus a week on trying to get it done. And before, before the cognitive issues, I would have been able to easily do that within the 40-hour week. So yes, I mean, and some of it is just starting the project, finding out, where to stop for the day, and then reassessing every day where to begin again. So yes, that really was, the processing was really slowing down for me.
Well, Debbie, just to kind of follow on that, did you have to request accommodations at work? Because of your issues? If so, what were they?
I did, and I do want to mention I was a federal employee, and that was a blessing. They were incredibly accommodating. I did request several reasonable accommodations over the course of my the last few years of my work, and one of them was working from home so I wouldn't be distracted, and also the commute, because I live in Baltimore and I was working in DC. So the commute was associated with fatigue, and I would get less done during the day if I was more fatigued, of course. So working from home was very helpful. Splitting up my hours, not necessarily a traditional work week, getting a break in the afternoon and then starting up again. Perhaps they were very flexible with my schedule, and I really appreciated that. I did not retire until I had exhausted all of my leave and FMLA and everything. I really loved the job, and it was very difficult to leave. But they were very accommodating during my career.
Thanks, Debbie. That's good to hear. I appreciate your sharing that. Megan, this I think is a good one as well. What constitutes cognitive dysfunction versus just normal forgetfulness?
It's a good question.
For all of us.
It's a good question. It's very normal to have forgetfulness. So we all kind of have that tip of the tongue phenomenon every once in a while. We all, there's even research studies about this, experience that walking into a room and not knowing why you went there, or forgetting somebody's name or something. So all of those things are very common. I think the difference, or the difference is the frequency and the intensity. So it may be that that happens to the typical person every so often, but if it starts happening so often that people around them start to notice that change, and it's impacting their functioning at home and at work, then it starts to become an impairment. If we want to talk about it from the neuropsychological perspective, what we typically do is we give some validated cognitive tests, so like a memory test, for example, and these memory tests have been taken by people in the general population without medical conditions. We take the person's score that we are assessing, and we compare it to other people who are the same age and the same education, and we see, are they performing about the same as their peers? Because we all over time, starting in our 20s, our processing speed declines over time. So there is some slowed processing speed with age. So we're comparing people's processing speed, their memory, their things like that, to their peers without MS, and who are the same age and the same education. If that person is performing about the same, then we're saying, okay, you might be noticing some of these things, but it's typical for your age and education level. If the person's performing much below their peer group, then we start to say, okay, this is not typical of people your age and education, and therefore it's likely due to MS if they don't have other reasons why, learning disabilities and things like that. Hopefully that answers the question. Yeah.
Yes, that was helpful. Thank you. So I have a question now that could probably be for either you or Debbie, or really for both of you to get your input on this. But on the call now, we have some of our MS navigators who answer the phones during the day and talk to people with MS. And how can they tell? How can a navigator tell if someone has cognitive issues? And really, I guess, to kind of build on that, how do they know if this person may need additional support, particularly if you have someone who doesn't realize they have cognitive issues?
That's a tough one. Do you want me to address that, Dr. Byer?
Sure, why don't you start?
Okay. Um, yes. I mean, I think a lot of my peers that have MS, I can tell. I mean, I couldn't tell on myself, but I could tell with them. And some of it is that word finding in, a conversation, short-term memory, perhaps they repeat things. And if they don't recognize it themselves, I mean, I think the referral is very helpful to, the neuropsychology program. And I am blessed to be in Baltimore and near the John Hopkins MS Center. And I know not everyone has that ability, but if they are near an MS center or it's possible to make a referral to the MS center, I think that is something that they can do. And I just want to thank the navigators for all they do. I've either emailed or called a couple times myself, and you do a great job. Thank you.
I know they're happy to hear that, Debbie.
Adding to Debbie, I think there may be times when you don't pick up on it, but I think, if somebody is having consistent word finding difficulties, that's a big cue. If they take a long time to respond, if the navigator asks a question and there's a long pause and they don't answer right away, or they ask the person to repeat themselves a few times, those can be hints and cues. If they start talking about difficulties at work or difficulties at home forgetting to pay bills, those can also be hints and cues. A lot of times I will ask the question, if I start to suspect, most of the time people coming to see me, it's because they have cognitive symptoms, but if I'm asking somebody about their own perception, I might ask, what have your family and friends noticed? Has anyone mentioned to you that, things don't seem quite right, or things have changed over time? Have you gotten any poor performance reviews at work, or has your performance at work changed? So I think asking some of those kinds of questions can get at cognitive changes that maybe even the person isn't noticing themselves.
Thanks. Debbie, I have another one for you. I know you have talked a little bit about how cognitive issues have affected you at work, but just kind of on the flip side of that, curious about how they have affected your relationships in general, and kind of in what ways?
Yes. Sadly, it's negatively affected relationships. I think mostly on the social end. Some of that is fatigue, but also sometimes, that anxiety kicks in about going out to dinner with friends, or in any environment. I might, recently, one example is, I met someone. I thought I was meeting them for the first time, and actually they had been in my work life about 4 years ago, completely drew a blank. I was very embarrassed by that, and so I might shy away from those social events if I'm worried about recognizing them, forgetting their name, word finding. You're just really are embarrassed, and so I'm much more a hermit, I would say these days, probably. I'm reluctant to go out with those that don't understand multiple sclerosis. I'm very close with my family, and there's several friends I have in my life that completely understand MS, and I feel very comfortable with them. But, if I'm out, I worry that people might think that I have dementia or something.
Do you find yourself educating people about the cognitive issues, or do you prefer just to keep that private?
No, I do. After I had a neuropsychological evaluation a few years ago, one of the first things I did was educate my family, quite frankly. And, like I said, the first, when you're reading through that evaluation on paper, it's hard to take, showing those deficits, but at the same time, it's validating. and you know, this is why I'm having trouble finding a word. This is why I might repeat the same story to you the next day, or this is why I can't remember what I just read. And you know, I do educate those around me as much as possible. My family is really in tune with the issues. Thanks for asking.
Yeah, thank you. Megan, we have another question where, you know, if someone doesn't live near, say they live more rural area, they don't live near an MS center or really have access to a neuropsychologist, what would you suggest doing if they want to get an assessment?
A good question. So I would say that at this point in time, if they have access to somebody who is a speech pathologist or an occupational therapist, those people can do brief cognitive batteries or brief cognitive assessments that can pick up on some of the difficulties that we've talked about. Like I said in the slide earlier, if they want to do something very brief and just track it for themselves, that CogEval app has been validated in MS. There's you know, this is a suggestion that has not been validated yet, but it's something that I'm working on. But there is something called the Many Brains Project, which has cognitive assessments that have been validated in the general population. And there are things, there are tests there that you know, people can give to themselves, but I think it's important for them to take that information, if they find it, to a primary care doctor or some sort of medical provider, because as we talked about, there's a lot of things that can impact cognition, and I wouldn't want people to take that information and run with it if they're not looking at the big picture of all the things that could impact their cognition. So I would say it's like first line is really, you know, seek out the medical care that they do have access to and see if there's somebody in the medical field around them, even if it's a primary care doctor that can give a brief screening like the MOCA. And then if they really don't have access to that, because I used to work in Seattle and we would have people who were coming from places like Alaska, where they were, you know, their primary care doctor was 7 hours away, then you can kind of consider some of these other options, and then but encourage them to reach out to the medical team that they do have, share the information, and have them partner to take next steps.
And Megan, we just had someone pop up and say, why aren't neurologists seeing these issues and making these referrals? Some of the callers they get are not even aware that neuropsych or cognition issues exist. And I think the paper you mentioned is certainly probably a start of trying to get people educated. I don't know if you have any last minute comments on that.
Yeah, you know, I think MS neurologists are pretty aware of the issues. I think general neurologists, there's still a need for educating general neurologists, because they deal with a lot of different diagnoses, and so and you know, in the past, MS has really focused on gait problems and things like that. And so I think there's a need to educate not only people with MS about managing their own symptoms or being aware of their own symptoms, but also the medical community at large, who are more generalists. So, you know, it's a need, and it's something that I think that we're all working towards, and hopefully as we do more kinds of trainings like this, the word will get out there, and we can start to change the tide.
So true. And Debbie, if you pop back up for just one last minute. Yeah, would just love to really to thank both of you for joining us today. You've been wonderful. It's been great to have you. I know, Debbie, you shared a lot about your personal life, and that's sometimes never easy, and we certainly do appreciate that. And Dr. Byer, I know you're very busy as well, so we appreciate your taking the time during the middle of the day here to join us. So I just wanted to remind everybody else that, again, you'll be getting a short survey that will pop up at the end. And our next call will be scheduled for January 24th, and that will be on pediatric MS. And in last week's Society News, we listed all of the calls for FY19, and the link to register is in that particular news sheet. So feel free to check those out for upcoming calls. And again, thank you, Dr. Byer and Debbie. We certainly appreciate your time, and this concludes our call for today.
Thanks.
Bye, everyone. Thank you.